Ladies, let's continue, ladies and gentlemen. Diabetic macular edema. We've done that. Features. Any edema normally will lead to thickening of the retina, and the retinal thickening is best detected with a slit lamp and a contact lens. When we say contact lens, we're talking 90D, 78D. There are various, some will put them on the cornea. Fluorescence angiography will show that diffuse late type efflorescence. The late type efflorescence means with time, as the fluid the blood which contains the hyperfluorescent material, when it comes to the fovea, it starts leaking out. OCT also shows retinal thickening. OCT also useful in assessing response to treatment. OCT determines the thickness of the retinal layer. The more thicker it is, it means there is more edema in there, more edema. These are the exudates, small exudates, the white stuff, the yellowish stuff. These are the exudates. They are coming from capillaries and showing. The red ones are the hemorrhages. And this is the fovea area, I think, there. Okay, so you can see all that. With this, definitely there is macular edema here. There's definitely macular edema, and the vision cannot be expected to be 6.5 or 6.6. To be worse, because there is edema here. There you are. This is the fovea, but there is edema just a bit out. When you see exudates like that, it means the point of leakage is in the center. Okay? Some vessel which is here in the center is what is leaking. Poco? Let me just. Okay. I said a message. I have a message myself. Which one?
Is the retina thickening localized, or it's the entire retina?
It is in some cases localized. It's not the whole retina which is thickened at the same time. You will find some areas where there is leakage from the capillaries. For example, in this one, I was showing here that this is the fovea area. So this is temporal to the fovea, and the center of leakage must be here. Then these are the hard exudates. There. Okay, fovea itself is intact. The vision in this particular case may be better, despite the presence of these exudates here. Because this is spared. But in some cases, you'll find this is occurring right at the fovea. Definitely, your vision or some patient's vision can't be better in that case. Types of maculopathy. I can continue. Okay. Types of maculopathy, I think I briefly talked about the earlier slide. We've got focal maculopathy, where you have well circumscribed retinal thickening associated with complete or incomplete rings of exudates. A good one is this one we've just seen. You see, focal maculopathy, this. The point of leakage is here in the center. So the exudates make a ring, but the point of leakage is here. These are exudates leakage from a vessel which is here, and they form a ring. Focal diabetic maculopathy, ring of exudates. So in the well circumscribed retinal thickening associated with a complete or incomplete ring of exudates. That's the best example I can give you. In fluorescein angiography, it will show late focal hyperfluorescence due to leakage. So when you do fluorescein, in the late stages of the fluorescein, the blood would have reached there. Because when you do fluorescein angiography, you are not injecting into the eye. You are injecting through the veins on the eye, on the hand or something like that. So this blood with the fluorescein has to travel until it reaches the eye. When it reaches there, that's where you detect that it has reached there because of the hyperfluorescence. It shows that it's now there. When there is leakage, these exudates, including the dye and exudates, they all leak together. And the blood vessel is leaking, the capillaries are leaking there. The other type is diffuse maculopathy. In diffuse retinal thickening may be associated with cystoid changes. Cystoid changes, that's where there is retinal thickening, but within the thickened retina, there are some empty spaces. Those are what they refer to as cystoid changes. You cannot see cystoid changes by doing a retinoscope. It will show when if you got that piece and went to stain, you know. Histopathology, you can determine that there are spaces within that retina. Not by looking at it. Okay, you can say it's thickened, but the spaces inside, you can't see them unless with that histopathology slide done. Fluorescein angiography shows late diffuse hyperfluorescence, which may assume a flower petal pattern if cystoid macular edema is present. Back to the original one, you find leakage now. It forms like a flower, flowers. It's leakage. This is the next one. The next maculopathy is ischemic maculopathy, which is variable. The macula may look normal. Mute. Diffuse maculopathy, ischemic maculopathy features are variable, but they show macula may look normal despite reduced visual acuity. It's the fluorescein angiography which will show non-perfusion. Fluorescein angiography is what tells you this is ischemia, which means blood is not reaching the macular area. So they will put in the usual fluorescein from here, then with time you start getting pictures there, and it will show fluorescein is the macula is being perfused or there is non-perfusion. So this maculopathy, focal, diffuse, and ischemic, as I'm saying, fluorescein shows capillary non-perfusion. You cannot say this is ischemic maculopathy without a fluorescein angiography. What is the basis? Because perfusion must show through that. So focal maculopathy, diffuse maculopathy, and ischemic maculopathy, those are the types of maculopathy which can occur. Diabetic ischemic maculopathy. Okay, this is just a picture. You cannot say it's ischemic until a fluorescein angiography has been done. which will show non-perfusion of the macular area. This is the fovea area. There is hemorrhages and the rot, but by looking at the picture, you cannot say it's ischemic maculopathy until a fluorescein angiography has been done, which will show non-perfusion. Then you can say this is ischemic maculopathy. Down there. That's the best. As I was saying, you can see these are areas of non-perfusion. The same picture, but we've got areas of non-perfusion, these blank ones, where there are no capillaries, small capillaries are not there. That's how you say this is ischemic diabetic maculopathy. If you just look at the picture, you can't make a diagnosis as ischemic maculopathy. It has to be this followed by that, confirmed by fluorescein. The only, how do you go about it? If you take this picture, it's the vision which is coming from here. It will be poor. That's when you say, let's take it, a fluorescein angiography. Then it will show you the non-perfusion. Then you can make a very, very sound diagnosis here that you are dealing with ischemic diabetic maculopathy. There's also this idea of clinically significant macular edema. What is significant clinically? It's retinal thickening within 500 micrometers of the center of the macula. There is, and this retinal thickening is because of the retinal edema. Okay, so retinal edema will show with retinal thickening. Exudates, you can have yellowish exudates, you can have blood coming out within 500 micrometers of the center of macula, if associated with retinal thickening. And the retinal thickening, one disc diameter, which is 1,500 micrometers or larger, any part of which any part of this patch, which is within one disc diameter of the center of the macula. That's what constitutes clinically significant macular edema. Because look, if you've got this large area of thickening and within one disc diameter, there will be edema at the fovea. If you've got these exudates, there will be edema at the fovea. This retinal thickening within is because of the edema. That's what is referred to as the clinically significant macular edema. That's the definition. It's not one. Retinal thickening within 500 micrometers, exudates within 500 micrometers from the center of the macula, if associated with the retinal thickening. And the retinal thickening, one disc area or larger, any part of which is within that the center, within the one disc diameter of the center of the macula. This, ladies and gentlemen, is the definition of clinically significant macular edema. Worth appreciating, worth knowing it. You can shine and shine, and there's some chap who asks, what is this clinically significant macular edema? And you'll be at a loss. We don't want you to be at a loss. Pre-proliferative diabetic retinopathy, remember we did the classification? Clinical features of the pre-proliferative cotton wool spots composed of accumulations of neuronal debris within the nerve fiber layer. They result from disruption of the nerve axons and the swollen ends known as cystoid bodies. In terms of signs, you have small, white, fluffy superficial lesions which obscure underlying blood vessels. Pre-proliferative. In fluorescein angiography, it will show focal hypofluorescence due to blockage of background colloidal fluorescence. When you do that fluorescing, there will be areas of hypofluorescence because there is blockage because of the exudates. Okay. Venous changes. These are generalized dilatation normally with tortuosity and looping, beading, focal narrowing and dilatation. Sometimes referred to as sausage, like a sausage normally when they're making a sausage, between the two sausages, they tie it. So you find the blood vessel is appearing normal, then thin here. That's what they mean by sausage-like pattern. Sausage-like pigmentation, segmentation. You can have intraretinal microvascular abnormalities, what they refer to as EMA. Note, EMA are arteriolar or venous shunts that run from the retinal arterioles to venules bypassing the capillary bed. Fine, in terms of signs, you have fine, irregular, red intraretinal lines that run from arterioles to venules without crossing major blood vessels. Fluorescein will show better, where you have focal hyperfluorescence associated with the adjacent areas of capillary closure, but without leakage. Those are the signs of EMA. EMA, intraretinal microvascular abnormalities. We're not going back. I did this. We are here. Not the next one. Yes. Arterial changes. You have retinal arteriolar dilatation. This may precede ischemic dysfunction, and you have peripheral narrowing, silver wiring of the vessels. What we're talking about pre-proliferative. From pre-proliferative, you go now into actual proliferative diabetic retinopathy. At least 1/4 of the retina must be non-perfused before proliferative diabetic retinopathy develops. At least 1/4 of the retina. So if it's a small patch, there will not be PDR, proliferative diabetic retinopathy. But once you reach 1/4 of the whole retina affected, then these new vessels start coming up. Fibrous tissue gradually develops in association with vessels as they increase in size. New vessels at the disc. Presence of new vessels at the disc is referred to as NVD. Okay? This is a neovascularization further away from the disc. The other one, neovascularization further away from the disc, may be associated with fibrous tissue, fibrosis, if you're in long standing. This is called NVE. There is NVD, new vessels on the disc. NVE, new vessels elsewhere away from the disc. Or NVI, new vessels on the iris. So these are the 3 possible sites where you get your where you can detect neovascularization. These will be small capillaries growing off. If you find small capillaries growing on the disc, it's neovascularization. Because normally, in a normal disc, you don't find the vessels in the actual disc. It's a white area. What you're worried about is capping or not capped. You see? But once you find the vessels growing on the disc, it's NVE. New vessels growing anywhere within the retina is NVE. new vessels elsewhere. Because the vessels normally which are in the retina, they are within the retina, maybe at a superficial surface of the retina, but not actually on. These are small capillaries growing on the retina. I'm sure there are pictures we shall see very soon. This is the NV, new vessels on the iris, NVI. You can see this is the iris, the red small vessels growing there. This is the NVE, NVI, new vessels on the iris. Okay. No, we're going down. Eh?
Right there.
Oh, it's right here. Okay. Clinically significant macular edema treatment. All eyes with clinically significant macular edema should be considered for laser photocoagulation, irrespective of the level of visual acuity. Treatment reduces the risk of visual loss by 50%. In other words, you people might be working in the rural areas. If you recognize that this one qualifies to be clinically significant macular edema, this is not a case you're going to be treating there. Send it to a center where there is photocoagulation, where it can be done. By keeping the patient there, the patient will be blind from bleeding. If you just refer, it means you've done a good job for the patient. Don't worry about 10 minutes. Don't worry. We're here. Where? All eyes with a clinical significance should be considered for laser photocoagulation. So we are coming here. Pre-treatment fluorescein angiography is useful. Before treatment, you do fluorescein angiography to find out exactly the extent of the leakage and to detect any ischemic maculopathy. Once that is done, then you are good to look at treatment. Treatment, focal bends. Bends are applied to microaneurysms and microvascular lesions in the center of the rings of Wechsler, located 500 to 3,000 micrometers from the center. This is the spot size, which you set. This is exposure time. And you can't just start. You have to be tutored how to go about it with experienced people. Then this is how it is. But once you are taught, you are good to go. Grid treatment. Grid treatment is putting dots in a line like that, then like that. That's the grid. Bends applied to areas of diffuse retinal thickening more than 500 micrometers from the center of the macula and 500 micrometers from the temporal margin of the disc. This is the spot size. These are features on the machine, which, Then this is the exposure time, which is set. Results, approximately 70% of eyes achieve stable visual acuity, which is good, instead of allowing a patient to go blind. 15% show improvement, 15% subsequently deteriorate. There's nothing you can do about it. And it takes about 4 months for the edema to resolve completely. Retreatment should not be considered early. So these are the guidelines. And this is how, after treatment, these are laser bends, these white patches. When you treat it, you don't see the laser bends. After some time, those bends become like white, like scar on the retina. So you can see that, this one, if patient comes, you will know that this patient had treatment of laser treatment. Poor prognostic factors to consider in diabetic retinopathy treatment. If there is a significant ocular ischemia. How do you know? When you do your fluorescein angiography, there are areas which are blank. You know, it means there are no vessels there. It's ocular ischemia. 2, exudates involving the fovea. A lot of exudates on the fovea. You can treat, but to clear those might be very difficult. Diffuse macular edema. This may occur together with edema and exudates. So even if you subject them to fluorescein angiography, to laser photocoagulation, it will not go. Because if you hit the macula itself, you are burning the macula, the vision will go. Severity of retinopathy at presentation. The more severe, the more difficult the outcome, obviously. So these are poor prognostic factors to consider when you are treating this patient. A patient comes with severe retinopathy, severe macular edema, you don't go for this laser. You're not going to achieve much. You know, significant ocular ischemia. There is no, there is already ischemia. So when you hit with your laser burns, you're not going to achieve much there. Exudates around the fovea. So these are poor prognostic factors. They are showing the outcome may not be very good. It will not be very good. These are features you find in the eye. What about systemic features? Uncontrolled hypertension. Poorly controlled hypertension and renal disease. So these are poor prognostic factors. Apart from that, I think they left here uncontrolled diabetes itself. Because some diabetics, they will tell them, no, take so much, so much. But someone doesn't want to take the medication. Once you reach such a stage, it's very difficult how to help you, how to help that patient. Other treatments for maculopathy, other lasers, frequency doubled, ND YAG laser, less destructive retinal effects than argon laser. This really, although they are saying less destructive, in Zambia, a place like Zambia, what would matter here is, do you have this type of laser? It's not something that you can, because there's a patient you can acquire tomorrow. Maybe you can ask if you are out in some rural area, find out what type of laser, the people where the patient, the eye centers, if they have that kind of laser, then you can refer specifically to there. Your center in the rural area won't have. Even if, for example, Eastern Province, I don't think they have so many centers with the laser. Maybe Chipata will have, but Eastern Province is not Chipata alone. There are other districts as well. So the importance of this laser. YAG laser, less destructive, and there's got short duration. Burns are applied to the RPE, retinal pigment epithelium. Intravitreal antivascular endothelial growth factors. Intravitreal antivascular endothelial growth factors. In other words, you inject in the vitreous to stop those blood vessels, the new blood vessels to grow. You put in the antivascular, anti-blood vessels. You inject there. And this is how it is done, intravitreal, straight into the vitreous. 0.5 milligrams ranibizumab. Initially, every 3 months, you get a dose. Then macular laser, or after 24 weeks, you look now whether you can go for laser. Intravitreal triamcinolone injection plus macular laser can help also. This is especially good in pseudophakic eyes. Who are pseudophakic eyes? I hope people somewhere know pseudophakic eyes. Those are people with it. Yes, implanted lens. The actual lens is removed. It was removed sometimes. Intravitreal something, you see, injection plus macular laser, not good in pseudophakic eyes because there's just an artificial lens there. No benefit in phakic eyes. Those who still have their own original lens. Pseudophakic, they've got an artificial. Phakic, they have their natural lens. Okay? So when you are going to do this intravitreal, these two factors must be considered. Where does the patient fall? Huh? Oh, sorry. Where does the patient? There we are. And it's done pars plana vitrectomy through the pars plana, indicated in cases of macular edema.